Hello, everyone, and welcome. A few reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the chat tool located in your Zoom control bar. We will address questions following the presentation. As you add your questions, please select all panelists and attendees before sending the message so everyone can see it. We will also have closed captioning. To turn it on, click the CC or closed captioning button on the Zoom control bar. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we're doing. Your feedback is vital in helping us craft presentations that meet your needs. As said before, all participants have been muted. If you have questions or need help during this call, please utilize the chat function in the bottom of your screen. You can private message UFOMA at School-Based Health Alliance admin, who is listed as host for technical assistance. All questions for presenters will be addressed at the end, but we will keep a queue, so please send them our way as they come up. This webinar is being recorded, and the recording and presentation will be available on the NCSD and SBHA websites after the webinar.
Hello, everyone, and welcome to Delivering Adolescent Sexual Health Services During COVID-19. This webinar is being hosted in partnership with the School-Based Health Alliance and National Coalition of STD Directors, with funding from the CDC's Department of Adolescent and School Health. My name is Jerica Davis, and I'm the Senior Manager, Adolescent Health at the National Coalition of STD Directors, and I'm joined by my colleague, Suzanne Mackey, Director of Policy at the School-Based Health Alliance. So I'd now like to present introduce our presenters for today. We have Dr. April Lee. She's the Director of the Division of Adolescent Medicine for the Department of Pediatrics at Staten Island University Hospital, Northwell Health, and Medical Director of the Division's School-Based Health Centers. Over the last several years, she has expanded programs that provide opportunities to increase the reach of existing clinical services to reduce health disparities, improve overall health, and disseminate prevention and education services to adolescent and young adult patients in the community. In addition to her role as director, she continues to be a dedicated clinician, educator, and researcher in the field of adolescent medicine. We also have Jen Miller-Allgaier. She is a pediatric nurse practitioner with Henry Ford Health System's school-based and community health program located in Detroit, Michigan. She provides care at Ruth Ellis Health and Wellness Center, a community-based health center that focuses on the health of adolescents and young adults with a focus on LGBTQ youth and HIV prevention and treatment. Jen has worked in Detroit for 15 years in the areas of pediatrics, women's health, and maternity newborn care nursing. In addition, she has nearly 10 years of experience as a research assistant with the Perinatal Research Branch, a division of the National Institutes of Health, working with clinical trials studying preterm labor, preeclampsia, and high-risk pregnancies, including those impacted by HIV. She earned her Bachelor's of Science in Biology, as well as Bachelor's and Master's of Science in Nursing from the Wayne State University. Her future goals include using Reiki for stress reduction in her current practice and pursuing an additional certificate as a psychiatric and mental health nurse practitioner.
Good afternoon and welcome. This is Suzanne Mackey from the School-Based Health Alliance. As the COVID-19 pandemic persists, many adolescents across the nation are either learning virtually from home or attending school in person in a modified or hybrid format. This webinar will address key considerations and best practices for school-based health providers related to telehealth, modified in-person visits, and planning for the return to full-time in-person learning. Presenters will also highlight approaches for providing inclusive, safe, and supportive care during COVID-19. So to kick off the webinar today, we are first going to hear from Dr. Lee. Take it away, Dr. Lee.
Well, hello, everyone, and I'd like to thank both the School-Based Health Alliance and the National Coalition of STD Directors for inviting me to participate in this really good webinar. I think it's going to be a great opportunity to share some of the experiences that we've all had throughout this past year. Next slide, please. I have no disclosures at this time. Thank you. just a few words about where our school-based health centers are located. We are in New York City, in the borough of Staten Island. If you look on that little map, we are the island in the lower left corner. Staten Island is known for the Staten Island Ferry, and we do look at the Statue of Liberty in New York Harbor. It is really a beautiful, lovely island community. It has more suburban issues than the other boroughs of New York City, and it's a bit more conservative than the rest of New York City. In the best of times, this is definitely a challenge in the delivery of sexual health services, but during a pandemic, it becomes a real challenge to us. At the beginning of March 2020, our school-based health centers were 0% telehealth. And then when New York went on pause, both New York City and New York State went on pause during the pandemic, our schools and our school-based health centers closed. By the end of March, we went to all telehealth services with some backup services at our sponsor organization. As the year progressed, we became more blended with in-person and telehealth visits. And as schools reopened for us all in the fall of 2020, some students chose to remain remote and some students had blended or hybrid learning with some in-person and some remote learning. And then of course, schools opened and closed depending on what the infectivity rate was at the time. Our practice paralleled this pattern of total remote for those who chose not to come back to the school or school health center with 100% telehealth, and some were blended telehealth and in-person visits. Next slide, thank you. So I'm just going to review very quickly for everyone. We're all, I believe, well skilled at taking a good sexual history, and these are the 5 elements of a sexual history that has been outlined in an excellent clinical report from the American Academy of Pediatrics Committee on Adolescence by Marcel and Burstyn, published in 2017. The first question would be about sexuality. Who are you attracted to, male, female, both? Sexual health assessment would be to describe your sexual experiences. Have you ever had sex? Reproductive life plan would be to ask if you've ever been pregnant, have you ever had children, are you planning to become pregnant, and at what time in your life? The sexual assault and sexual abuse questions would be about a history of coercion or trauma. And then the last S of the questions are the sexual problems, but also don't forget to ask the question about sexual pleasure because they should describe good and bad. Now, finally, we all know to ask open-ended questions, particularly to anyone about sexual health, gender-neutral questions. But in a telehealth world, can you really continue to ask open-ended questions? And so that's what we're going to discuss a little bit later in the course of this presentation, how maybe your questions in the line of questionings may change a little bit in a telehealth session. So telehealth is certainly not new to school-based health centers, as seen in this graph based upon the data from the School-Based Health Alliance's census reports in 2013 to 2014, and then again in 2016 to 17. There was a huge growth of telehealth services in these telehealth exclusive school-based health centers, which means no provider was on site. Student received services in a school-based health center totally through telehealth. And there was a huge increase from less than 1% to over 11%. And what's the absolute number? A little over 250 school-based health centers reported in 2016-17 that they had exclusive telehealth services. 56% were in rural locations, not surprising. 3/4 of them provided medical services alone. 1/4 of them provided both mental and medical health services. Now, does sexual health services translate well to telehealth? In an article published by Barney and others, pretty early on in the pandemic, based at UCSF, they reviewed their adolescent and young adult services, and their services went, like a lot of us, from 0 telehealth to 97% telehealth. And they found that though there were challenges, They found that reproductive health services, specifically contraceptive counseling and education, translated well to telehealth. Now, users of school-based health centers usually describe the setting as a safe, supportive environment. That's why students come to visit school-based health centers. With the decreased access to users, the challenge of school-based health centers going forward during this pandemic was to somehow recreate that environment into a virtual world. And one big advantage that we had was that our age group of teens and young adults are relatively tech savvy compared to other age groups. So I want to just define a couple terms first. I may use patient and student interchangeably, sorry, but they are student patients in a school-based health center. And telehealth, I'll define as audiovisual and audio, which is telephonic only. So we all know that the art of healthcare is a good bedside manner. Well, I'll be describing instead a good website manner in this slide. As a provider, we have to be mindful of the nonverbal cues as we look upon ourselves on the video. Our voice needs to be warm, comforting, especially if it's a telephonic visit only. In the camera, you have to have good eye contact, look into the monitor, lean into the screen, nod, smile. In other words, good body language, which you would have done in the office setting. You just have to somehow translate that onto a screen. Avoid distractions and fidgeting, which I personally have a hard time doing. Try to refrain from typing. I know when we all moved towards EMR and electronic health records, we felt that we weren't looking at the patients anymore because we were looking at a monitor. Well, now we're looking at the patient and possibly a split screen where we're looking at a patient and their EMR at the same time. So try to avoid the typing. With the patient, when you look at the patient, be aware of the patient's tone, their facial expression, their body language, and respect the silences. Allow for a delay in responses because sometimes your internet connection may not be the best and they may not capture everything you're saying, and you may have to repeat yourself over and over again and ask, did you hear me? Did you understand what I just said? And because there will be audio and video delays sometimes. So understand that there may or may not be problems. And in addition, have a plan in case you don't have good internet access. Always try to confirm contact information early on in the visit in case there's an emergency or patients in a crisis, or best is that if their internet access may not always be best. I've had patients go from one end of the sofa to the other end of the sofa and we've lost connection. This way that you can confirm that you have access in the future, and a future in a teenager's mind may be the next few minutes, it could be an hour, it could be when their cell phones have charged up again. The other important change that we all had to modify going into telehealth was when you're in a school health center, you just usually say, hi, my name is, I'm going to be your clinician today. I'm going to be your health educator today. I'm going to be your social worker today. How can I help you today? This time now in a virtual visit, they may not know your voice. They may not recognize you right away. You may be masked so they don't see your face. So you introduce yourself again. My name is, this time you say, I am the clinician from your school-based health center. This could be the same voice that they heard from another place. So, you know, if you represent the sponsor organization, which I do, you never know which side I'm going to be in. So I have to clearly say I'm representing the school-based health center today. How can I help you? So in other words, you recreate your virtual room in a school-based health center setting. So one aspect of school sexual health services that I will very, very briefly touch upon, because the focus today is really on sexually transmitted infections, is contraception. It was a common question. The biggest challenge was that we were no longer dispensing on site since we had limited or no access at different points of the pandemic over the past year to students. So it depended if we were able to reopen or not, we were able to dispense. But we had to change our practice to more of a prescription practice, identifying pharmacy, telling students or patients, teenagers, how to fill a prescription, how to go to the pharmacy, what will happen at the pharmacy. This is what you're going to need to bring with you when you go to the pharmacy. And that was most of the counseling. And once we prescribed, you tried to do it as long as possible, if up to a year if possible. A lot of my students' plans were only allowed up to 6 months. Renewals were much easier because you already knew a little bit more about, in the chart notes, about their blood pressure, weight, and height. Occasionally, you'd have to start initially with a brand new patient, and I've done that a couple times. It's good to know it takes a little bit longer in terms of getting a history, but it can be done. And can you traditionally start? Yes, at the time of their period. And you can also immediately start. Now, if what's missing is clearly a physical exam, blood pressure, height and weight, if preferably to have a pregnancy test. However, I did accept home pregnancy tests if they had it, or if they could give me a careful history of recent sex and whether protected or not. And then with the progestin injection, that clearly had to be an in-person visit. So people got really creative in terms of giving continuation of an IM injection. Sub-Q could be sent to the pharmacy. Sub-Q could be given by the individual themselves if they were up for it. I never had a patient, unfortunately, who was interested in it, but I've heard other providers say that they were able to do it, and they were able to teach their patients through a virtual meeting how to inject themselves. Another way of bridging or using a different method would be to move to a combined hormonal contraception, or if estrogen was a contraindication, to move to oral progestin pills only. So the reference given on the bottom from the Reproductive Health Access is excellent. It's a great website. The key here is creativity and flexibility when you're prescribing or continuing. And this is, I apologize for the size of the table, but it's a great workflow. It comes from Wilkinson out of the University of Indiana. This was published in JAMA Pediatrics in the summer of 2020, and it provides a great workflow as we all had to recreate our practices into different types of workflow last year. So the title of the article is "Providing Contraception for Young People During a Pandemic is Essential Healthcare." It talks about delivery either being, if you're limited and you cannot get on, if you can get on site, great, but if not, curbside, setting up nurses visits, giving guidance in the upper right box as to the type of history. If you're initiating, in the lower right box, the questions to ask about past medical history. And then finally, about contraception, those patients, who had long-acting reversible contraception or LARC in place, but were due for replacement, the guidance given at the Reproductive Health Access, which is a reference at the bottom, was that, yes, the FDA had an approval for the hormonal implant for 3 years, but evidence-based references did show that you had good serum levels for up to 5 years. So if someone was unable to come in person to replace the hormonal implant, take one out and put a new one in, you did have time. Same thing for the copper IUD. It's FDA approved for 10 years, evidence-based, though you can keep it in for 12. With the levonorgestrel IUD, there's a lot of variability between the different types. So I would just say to look at the references. Everyone is slightly different. And if need be, you bridge to another method. If you feel that they have gone beyond that time period, you bridge to another method like a progestin only pill or another type of combined hormonal contraceptive. Emergency contraception, I just mentioned here, that really didn't change in terms of guidance. That could be prescribed or picked up in a pharmacy for the levonorgestrel or the ulipristal. And the copper IUD obviously needed an in-person visit. Bottom line is, with contraception, it's patient-centered contraceptive counseling. It ultimately, the choice has to be tailored to the individual needs. It's just that the barriers were greater than in a regular school-based health center setting in terms of prescriptions, payment, ability to pay for these prescriptions, ability to even leave the house. When we were on pause, people were asked to stay inside the house. I think it is a little bit better now. Some people are a little bit more comfortable about leaving the house, but for kids who were told they can't leave the house, it was difficult for them to arrange to pick up prescriptions. If they were creative enough, they were figured out how to get deliveries. There were a lot of different ways. Again, creativity, flexibility was really key. If they worked in a supermarket, we changed the prescription to the supermarket that they were working at if they had a pharmacy at the site. And follow-up was essential. And again, in a school-based health center, you would normally have walk-ins all the time, and you try to fit them in as best you could, but you couldn't anymore. There was no place for them to actually meet you. So when school-based health centers are closed, you have to schedule these, and that's a challenge, because kids' day-night cycle were different. They tend to ask for later in the day, or after remote learning was over, or when it was more private and they knew parents were out. So, and you got to remember, the entire family was in the house. So there was not a lot of privacy. Yes, a lot of family time, great, but not a lot of privacy. So that was one of the biggest barriers, trying to figure out when to do this. So in terms of sexually transmitted infections, there were many telephonic and telemedicine-based approaches, and the CDC gave good guidance in terms of male urethritis, suspected primary or secondary syphilis, vaginal discharge, and proctitis. So basically, they took clinical symptoms, and since there was little access to in-person visits, which you would normally do as a standard, and there was, as if they weren't in person, then it was difficult to do testing. What was important was to establish a triage protocol to see if you could figure out who might be at most risk and try to follow up with those people. Again, the standard in-person labs and treatment is usually on site, treatment requiring an IM injection at times. And that clearly was an in-person visit. So with a telehealth visit, the CDC gave guidance to treat a number of STIs with oral antibiotics that did not require an in-person visit. So based on a conversation you may have in a telehealth session, please describe what's happening. You would decide whether or not to send a prescription to a pharmacy. Unfortunately, there were shortages of these antibiotics. So cefixime sometimes was in short supply, as was azithromycin. Alternative antibiotics were recommended. So that's why you see so many antibiotics on the screen, but you're basically trying to treat both gonorrhea and chlamydia for a suspected urethritis with either cefixime or cefpodoxime, and in addition, azithromycin or doxycycline, whatever you were able to get. With suspected primary or secondary syphilis, basically the presence of a non-tender genital ulcer in a male or non-pregnant female, you could prescribe doxycycline 100 milligrams twice daily for 14 days. With a pregnant female, there was no alternative. You had to give that injection of penicillin. And again, evaluation was based on description, self-report, and personally, I discourage videos and photos. Also, during the course of the year, diagnostic STI test kits and lab supplies were in short supply. We dealt with that at some point. So it was, ironically, we'd have an in-person visit, but then we'd have to empirically decide, are we treating, what are we treating? So when there was a short supply, fortunately, we've gotten more test kits since then. I don't know, it'd be interesting to hear if anyone is still in this position now. There was a prioritized site that you would do. So for example, in females, it was recommended that if you didn't have a lot of test kits, do a vaginal test, not an extra genital test. Or for males, it would be rectal over pharyngeal over urethral. Again, vaginal discharge was based on the description that the person would describe. and you would treat with metronidazole if you suspected BV or trichomonas. Candida would be treated with anti-candida. Medication for a suspected proctitis, again by the patient's description, you treated for both gonorrhea and chlamydia with this cefixime and doxycycline, or cefpodoxime and azithromycin and doxycycline. So here the key really was follow-up, because if you needed to follow up with them 7 days later, and sometimes it was hard to get them, but you really had to persist and keep like a record of who you needed to follow up with, because if it didn't get better, then some people did try it again a second time, whatever they treated with, but it sounded like at that point you needed to convince them they had to come in for a physical as well as lab testing. Now, expedited partner therapy is recommended by the CDC, and this is the CDC guidance, and the website is listed in the lower right. However, legal restrictions vary state by state. The recommendations really didn't change all that much for chlamydia. For gonorrhea, clearly we weren't bringing them in. If we were not bringing them in for IM injections because they were unable, I mean, we wanted them in, don't get me wrong, we wanted them in, but if they were unable to come in, then we had to give oral antibiotics. For their partners, you could prescribe oral as well. But syphilis, that is still not recommended for expedited partner therapy. The partner needs to be treated with an IM injection of penicillin. Now, there was a question, I believe, in the chat box about availability. How do you procure this? It is true. If azithromycin 1 gram, relatively, and still it's a challenge, and it amazes me to this day why it's still a challenge, but it's a challenge. In New York City, the way it's done is a paper prescription is written, and you can write EPT. You don't have to identify the partner, and you can give that to the patient. However, if azithromycin is not available, then you had to go with doxycycline. Either way, sometimes it remains a challenge to do it. Sometimes you could ask the person to come in, and then that is actually helpful, because then you can do all the testing, and that makes it somewhat easier. Otherwise, you have to get a little creative about getting the extra doses. And we can talk a little bit more about that later. Let's see. HIV, again, the counseling can be done virtually. And it's preferable if you have someone who wants HIV testing to do it quarterly. But if they are in, isolation, or they've been quarantined, it's difficult for them to come in. I think Jen's going to go over this a little bit more in her presentation later about possibly starting PrEP during this time frame. Again, did I do this? Probably not through the school-based health center, and I did it through the sponsor agency, and I actually did it in person. It's just a little bit easier in terms of doing the testing prior to starting PrEP. Now, there were a lot of challenges. There's no question. I think we can all share that there were a lot of challenges this past year. And some of them I've just listed up here. The potential limitations include limited access to the internet or technology device. And I'm talking about both the provider, on the provider's part, as well as the patient. Sometimes I lost internet access. Sometimes we couldn't get connected for a lot of different reasons. A level of comfort with technology for the provider. Now, a lot of providers don't want to be on camera. That's fine, and as well as the patient. We are fortunate, like I said, because we're dealing with adolescents and young adults who are supposed to be tech savvy. And there are situations where in-person visits are more appropriate due to the inability to perform an adequate physical exam or testing. You have to remind some of the teens, sometimes with the comfort level with technology, that they've got to charge their device, be ready and be prepared for this visit. So it's often helpful to have somebody explain what is expected in the visit prior to it. So charge your cell phone beforehand. Stay in an area where there's good connectivity. Unfortunately, a lot of times the way most homes were set up is that the best connectivity is in a public area like the kitchen or the living room. So that becomes a problem with privacy. Okay, so again, scheduled appointments preferred with a telehealth visit. Uh, so again, in the school-based health center, we would always have walk-ins. So it's very hard to switch gears and then go to a scheduled appointment plan. And then one of the challenges I didn't put up here, but in terms of counseling and education, and I think the health educators who are on this webinar know what I'm talking about. Usually you did a hands-on explanation of different things, whatever it was. You had charts, and it's a little difficult to do that when you're remote or when you're virtual. So sometimes I would refer people to websites, have them check out websites in advance. Sometimes we were able, as technology got a little better at my site, we were able to share screens a little bit more, so I could have something up on a website and then share that screen with them later on, like CDC guidance on something. So in terms of confidentiality, the policy needs to be explained at the onset, at the beginning of the visit, to your patient as well as whoever else is going to be in the room. And a good guideline is the American Academy of Pediatrics Bright Future for Minors. Consent and confidentiality laws vary from state to state. A good reference here is the Guttmacher Institute, which is on the bottom there. Assure patient of confidentiality as if you were in your school-based health center setting. Everything is shared that stays between us is in this virtual room. Of course, if they're going to harm themselves or harm someone else, then that is no longer true. But for the most part, confidentiality in a virtual room, you try to do the best you can. But you have to ask if there's anyone else in the room and make sure that no one else is there. Let's see. Explain what your expectations are in the telehealth visit, and then allow patient time to express their concerns or their expectations out of this telehealth visit. And sometimes you can meet their concerns. Not always, but sometimes you can. In terms of privacy, you want to meet at you want to make sure you're scheduled at a comfortable place at an agreeable time. Ask if there's anyone else in the room. And if they're not comfortable because, somebody's in the room at the time, you can reschedule. You have the right to reschedule. And it might be 30 minutes from now, sometime in the future. And future can be 5 minutes, or it could be the next day. If they say they want to stay in the room, I'll also make sure they have a good internet connection. And if they want to stay and they want to continue, I would recommend at this point to use a headset for them. And I will ask them, is there somebody in the room? Are we going to yes or no questions? So yes, I would love to continue the conversation in open-ended because you get so much more information, but you may not be able to if someone's in the room. So you switch to yes and no questions. Some people have recommended that they type in the chat box their answer. So it does vary. And again, flexibility is key. It's important to identify and confirm contact information. How can I contact you confidentially if I need to as a follow-up of this visit? Who has access to voicemail on the cell phone in the beginning of the pandemic? It's amazing how many people lost their cell phone, broke their cell phone, didn't have a cell phone, but were supposed to get a new cell phone, but were unable to at that moment because they couldn't leave the house, couldn't get a delivery, couldn't get to the retail store, whatever it was, they did not have. So they were sharing phones. So if they were using dad's phone, maybe I don't want to leave a message on dad's phone, and I'd have to explain that. Who has portal access? Unfortunately, at my institution, we do not have portal access for minors. However, for those lucky people who do have portal access, then you want to know who else has access, what parent has access to your portal access. to your portal notes. And then finally, email. Who has access to your email? Are you using the school email? I tried to discourage people from using their school email because I don't know who else is reading the school email. But if they had a private email account, that's what I would try to obtain. Now, I never thought prior to the pandemic that I would ever need a child's or student's or patient's email address. But now I've suddenly become enlightened and I realize now the importance of having an email address. It's a great way to communicate. It is not secure. And I do remind them it is a not secure way of sharing information, but it's a good way of just touching base. Hi, can we schedule a time to talk? Okay, so I'm not an expert in billing, but I'm just going to touch briefly on this right now. In terms of telehealth services, the federal government had taken steps to make telehealth services easier to implement and access during this national emergency. And for the duration of the COVID public health emergency, the Centers for Medicare and Medicaid Services will reimburse telehealth services, and that I believe is medical for sure, and some mental health, in lieu of many in-person appointments. And again, the reference below is from Health and Human Services. When billing for the telehealth claims for services on or after March 1st of last year, and for the duration of the pandemic, you need to include the place of service, the POS, equivalent to what it would have been. So that would be your school-based health center. Append a modifier 95 to indicate the service took place via telehealth. And this is video audio only, so that you want to show that it was a synchronous visit, not asynchronous, but synchronous visit. And then you use your regular CPT codes. Coding for a telephonic visit happened. They'd established codes after on April 30th of last year. And there are some restrictions with the telephonic visit. It must be patient initiated. It cannot be separately billed when a call is related to face-to-face or telehealth visit within the last 7 days, and the call resulted in a patient being scheduled for an appointment within 24 hours of the call or the next available time slot. So now in terms of billing, Medicare is supposed to pay at the same fee-for-service rate as in person, and this is payments for, but payments for telephonic only has been a struggle. It is much less, but I hear it's increasing. In terms of Medicaid, it will vary from state to state. And the National Policy Telehealth Resources Center lists state-specific billing for reimbursement policies. Again, it is the second reference on that slide, the National Policy Telehealth Resource Center. Now, some states do have expanded Medicaid services to cover specific reproductive healthcare services, and the Affordable Care Act will provide preventive services, so counseling services are covered. But again, it is a state-by-state interpretation. So with my final slide here, what are our next steps? As we look back, what have we learned in this past year? And as I am happy to see more students returning to in-person learning, and as we go forward, and who knows what next fall will look like in terms of school, and will we be fully in person? Will we be a hybrid of some kind? I don't know if anyone knows the answer to that yet. What will we keep and what will we continue? So one big concern is the provision of sexual health services. Are we basically catching up now? And I think I've seen at different times like a rush, depending on how open we were in New York City or on Staten Island at any given time, or how if kids were back in class, or if they close the school or they open the school. When they open, sometimes we'd see a rush of kids that we'd screen for chlamydia, and maybe 3 or 4 in a week would come back positive, as opposed to seeing them spaced out over the course of the semester. So I think we have a lot of catching up to do. We need to prioritize who we need to contact and who's at risk, so we need to call in sooner. Going forward, what is the role of telehealth? I think it's going to play some role. It's going to continue for a little while to a certain extent. What is our responsibility for incorporating behavioral health screening? I think kids have suffered. We've all been through this periods of isolation, and kids are just coming to us now. And if they're coming to us for reproductive sexual health services, this is a time to continue that good work that we do in terms of behavioral screening. With HPV vaccination, I know at some point last year, maybe in the spring or summer, the VFC reported that there were less sites ordering HPV vaccines, as well as vaccines in general. And I know we did decrease in terms of childhood vaccines, but what is the best way of preventing HPV-related complications later in life, but prevention in terms of vaccination? So we have to keep on top of that. I know that for my sites that we've been able to stay steady. We've been able to bring them in and keep it going. And I believe that is the report from New York City as well. Not sure how the rest of the nation is doing at this moment. I think it's still a little too early to know the data. And then finally, the big challenge I see is meeting the new students. Now, normally in the next fall and the new year, as we look forward, yes, we spend a lot of effort meeting the freshman class or the brand new students in the school, but we've got to look back. We didn't get to see most of the students from the 2021 academic year. And honestly, we didn't see them in the last quarter of the 2019-2020 year. So we're missing a lot of kids that we could have touched in some way, just to introduce the services. I just met somebody not recently who, it was clearly a sophomore, who says, you guys are here, you do this, you know, and I can get these services without my mom. Yes. So yeah, tell your friends. So we are fortunate in that in our particular program, we have a New York State grant from the Comprehensive Adolescent Pregnancy Prevention Services, and our health educators have been pushing into the classrooms throughout the year. And this has been great outreach, because what they do, in addition to discussing risk reduction, and they've been identifying, you know, resources where they can go, students can go for health services. So if they've been in a school that we have a school health center, they've been referring to our own health center. So that's what we have to continue, even more so starting in the fall. Okay, I think that's it for me. Thank you for the time.
Thank you, Dr. Lee. So now I'd like to introduce Jen Miller-Algier. She's going to share about her experience providing sexual health services during COVID-19 at the Ruth Ellis Health and Wellness Center.
Thank you so much for having me here. Really, I'm excited to share. So as was mentioned, I work at the Ruth Ellis Health and Wellness Center, and we're located in Highland Park, Michigan. Oh, before I continue, I should say I have no disclosures or conflicts. And it's a small city that's surrounded basically by Detroit on 3 sides. And so it's essentially part of Detroit geographically and demographically. It's very similar. The health center that I'm in is an adolescent health center that's very unique in the way that we are embedded within the Ruth Ellis Center organization, which is a social service agency here in Highland Park, Michigan. And they have a mission to serve LGBTQ+ adolescents and young adults. And our work is part of the school linked program for the Center for Child and Adolescent Health Centers of Michigan, which is funded by the MDHHS. And then additionally, we have other grant funding from HRSA and Ryan White to provide HIV prevention and HIV treatment. So we're a little bit different than probably some of you in the way that we're a school linked health center. And instead of being inside of a school building, we are located inside of a community center, essentially. And we have multiple funding sources and slightly different a shift in our age range. Now, we technically serve clients that are between the ages of 10 to 21, but with the way that that pans out, because of transportation and access, that most of our clients end up being between 15 and 21. Okay, So Dr. Lee did a phenomenal job about talking about how this works and how everything has gone through and been rolled out. Her talk was very comprehensive. But I'm going to speak just a little bit to our specific health center. So just to give an example of things that we were able to do, or things that might be opportunities for other organizations to look towards. So our experience of the pandemic was that in the early times, we closed the health center for about 2 weeks. And because we're not located within a school building, we did have the opportunity to open up much sooner. Lots of the schools here are closed still, or open just for hybrid learning, partial in-person, partial virtual. And a lot of our school health centers did not have the opportunity to open back up until after the first of this year. However, we were closed fully for about 2 weeks. And then we returned to our health center. And by we, I mean myself, and a medical assistant was initially the main team, with everyone else deployed to support COVID activities and different support services throughout the health system. And so when we did open, we were primarily spending a lot of time talking to people by phone, trying to get them enrolled into our MyChart system, our Epic MyChart, so that we could start establishing video care. But for the first few weeks, there was a lot of telephonic telehealth going on, and was touching base with people to see how they were, what they needed, if they had had anybody impacted in their lives by COVID, and just really trying to ramp everybody up in, to the EMR. We made really great efforts and extensive efforts. And by summer of 2020, we had opened partially back up so that we were seeing people more in person than we had been in the months prior. And the way that we were able to do that was by, instead of having maybe a 20 or 30-minute slot, we were now having hour slots. So there was time for tending to the cleaning efforts and distancing and spacing individuals. And every time we did see someone in person, we always made sure to prioritize having them enrolled into the MyChart system, so that we could have follow-up visits that didn't require in-person services to be virtual. At first, we were a little bit nervous about this method. We were worried that there wouldn't be much uptake of it. We do serve a population that is at high risk for homelessness, and we do have a good number of clients who are homeless, but we were really surprised that almost everyone was able to utilize the MyChart portal for having appointments, for sending questions, for requesting their refills. And so we were pleasantly surprised that that was the case, because initially we had never pushed that part of our availability with our system, because we didn't think it would work, but the pandemic helped us learn that it did. So that was really useful. So we can go to the next slide. And so specifically around STD testing and treatment, we had 2 different ways that we were doing things. And I want to keep in mind that during this time, my site was the only location throughout our program that was open and available. So what happened was that if there were individuals from other school-based health centers that needed services, they were then referred or funneled to our location. So we were helping to continue contraception, specifically like depot injections. Most of our in-person visits when we first started seeing people in person again were for those types of things. So we weren't doing a whole lot of like counseling and education on site at first. We were just doing the nitty-gritty in-person things and handling all of the counseling and education virtually. But there were 2 ways that we handled things. If someone was a new client, new to school-based or to the school-linked health center, we would try to do a virtual or phone history and education session first, and then have them follow up that week with an in-person, just for a collection of specimens and that kind of thing, if it was needed. If presumptive treatment was possible, we would do that. But there were still a lot of clients that were seeking screening, right? They didn't have symptoms, but they just wanted to quote unquote be safe. And so for those times we were doing the in-person collection when there was no symptoms to be treated. And then we would notify them of the results, either by phone or by a follow-up visit, depending on the client preference. Now, if people were already existing clients, they were being scheduled in the reverse. We had already had established care with them. They would come, they'd have their tests collected, and then we would call and do a follow-up phone or virtual visit to give the results, the education, and that kind of thing. If treatment was needed in those cases, we would do that by sending a prescription out to them. Or if it was the situation where someone needed to be treated for syphilis, because we do have probably about a half dozen cases a quarter, then we would have them come in for that injection. Dr. Lee did a great job of describing the oral treatment and the medications and all the alternatives. We do have the really large luxury, I will say, and that our pharmacy has a grant program, and that really allowed a lot of ease for us for treatment, as well as for EPT, because of the grant funding that we have that supports copays and the payment of medications. We were able to have people's medicines delivered to the health center for them to pick up, including EPT, and also because of some of the pharmacy benefits with COVID, with there being, with some insurance companies and with our pharmacy in general, the ability to FedEx 24 hours, same day, the prescriptions that we wrote to clients and or their partners, we were able to get them to them more easily than some locations may have, because we have access to that infrastructure that was really, really useful. It's very useful for lots of things, but in this case, it was really great to be able to get people the treatment they needed if we could send them oral medications and they did not need an injection. EPT for me is very tricky. I agree with, there was the person who asked about chlamydia treatment with EPT, and the EMR can sometimes pose a problem because we can write the script in Michigan, the generic script. However, I don't have a lot of paper scripts available, and a lot of times if we were doing this over the phone, where we were giving, or the virtual visit, we were giving presumptive treatment, the ability to get somebody a printed script was also difficult. So for me, this was challenging. The way that I resolved it predominantly, and I could do this because I wasn't super busy at this time of the pandemic, was that I would call in, I would have clients have their partners call me, and then I would call in the prescription for them for their EPT. So that was challenging, but that was the workaround that worked best for me. And I was able to do that because I wasn't, during this point in time in last spring and summer, so overwhelmed or overloaded with clients that I did have that time available. So confidentiality, again, Dr. Lee did a really great job on fleshing this out and talking about all of the things that are really important. And so our program has measures in place that have always been there for our school-based health centers, which are, we don't send home any mail at all, period. They don't get anything from the health system whatsoever, no surveys, anything like that. We have on our back end, the billing set up such that we use a special guarantor, so there's no explanation of benefits or anything like that. So that's really great. And then we also have the luxury of having a minor MyChart portal available. So young people and clients 14 and up in the state of Michigan are able to seek services for sexual health, reproductive health, and some mental health services privately, and our EMR is set up that after 14, parents are no longer able to access anything but basically the scheduling information. So they don't see notes or test results or anything. They don't see conversations or messages unless they have the direct login, which we discourage the young people from giving their parents their login for that reason. So that became a really useful tool for us to communicate and be able to set up appointments and give test results and that kind of thing. Because calling home, as Dr. Lee mentioned, you don't know if you're going to get dad's cell phone or who might pick up the client's cell phone. So my chart became a really useful way for giving that information out. And another benefit that we have in the state of Michigan is that our MDHHS program does provide payment waivers for us so that we didn't have to use people's private health insurance to prevent, again, explanation of benefits from going home or bills for those people who were privately insured. So that was another benefit to us having and maintaining confidentiality. So another thing that we found when we were transitioning and trying to have everyone have as much virtual access as possible was that we wanted to make sure that we were integrating everything, mental health, and all of the services. So the BH team here is also using Epic. Here at Ruth Ellis Center, our behavioral health team within our school-based program uses Epic, and our health system quite early on started utilizing a program called Videoly, and so our behavioral health services were seamlessly transitioned to virtual. In the case where it wasn't private or it wasn't possible for young people to be accessing video, or some kids really said they just sorry, I keep saying kids. Some young people really didn't want to be on video. They just would prefer to talk. Then, they could turn off the video option. And we were able to maintain mental health services in that way as well. And here in Ruth Ellis Center, our current focus is on Wayne County. And so for people who are living outside of Wayne County, we're utilizing our greater school-based program. And there's also a housing program here at Ruth Ellis. That program was closed for a bit in the beginning, and now it's reopened. And we were also able to access people who are outside of Detroit through the telehealth services, which has been really great. And we're short on time, so we can skip this last slide, because Dr. Lee basically covered that as well. And there's my contact information if anybody ever wants to reach out.
Thank you so much to both of our presenters. So now we're going to take some questions for both presenters. So if you submitted a question in the chat, we can ask that. And also feel free to submit a question in the chat if you haven't done so already. So we had a question earlier. I believe it was for Dr. Lee. When will the federal government stop covering telehealth visits?
That's a great question. I wish I had a crystal ball to know when. As long as we're in the pandemic, I believe nothing will change. But having said that, you never know. So I don't know. I don't think anyone knows the answer to that, unfortunately, at this time. But as long as we're in the public health emergency, we will continue to follow the same rules and guidance that they put out in the spring of last year.
Thank you. If anyone has any other questions, you can feel free to submit it in the chat. So can you, I'm not sure, which presenter this is, Dr. Lee or Jen, but anyone can answer. So can you talk about the unique challenges telehealth may present to high poverty or underserved communities?
Well, I can say for the clients that we are serving that access to technology, access to Wi-Fi, a private space, those are all really important limitations. Some of the ways that we have gotten around them is that at Ruth Ellis Center, the community center, they have sought grants and funding and have received phones and tablets and that kind of thing to give to clients. Now that's not always accessible or available. They also in the beginning had some phones and things that were donated, and people being able to have access to a functioning phone without cellular service, but that could be used on Wi-Fi, whether that be Wi-Fi at a shelter or Wi-Fi on site if someone was having a meeting with a social worker or something like that, would allow them to check into their portal and that kind of thing. So there were creative ways for people to access their portal. Now, it wasn't always ways that would allow them to complete a telehealth visit. So some of my most at-risk clients, so say people in foster care and people that are homeless, they did require additional help to have a virtual visit. So I've had people conduct their virtual visits at the office of their case manager if they were in foster care, or I actually have had a couple of clients that I'm here in this building and they're across the street in the Ruth Ellis Center building with the social worker. So we're basically just across the street from one another, but on the computer, because that was the only way to have them to be able to get access to the technology. So, and the reason they would have to do that was because the in-person visits, because we spread them out to an hour to allow for that time, it left less availability for the provider on each given day. So, and we were also only having one provider see clients at a time, whereas before they were on Mondays and Wednesdays, 2 providers. So that again reduced the availability. So having people be able to access the virtual care, even if it was from a computer across the street, was better than delaying it weeks. So those are some of the limitations I've seen with our clients that are experiencing poverty.
In New York City, if you attended a public school, there was a huge effort to provide the devices that you needed. And within a school, if you were in the school building when they reopened, they did provide Wi-Fi in the building. So that helped reduce it a little bit. And it increased access to telehealth if that's what they needed.
Thank you. So we have another question. One of the attendees works in child abuse and neglect prevention, and there have been increases in reports of domestic violence, emotional abuse, and screening for sexual abuse. It has all been a challenge. For example, the abuser may be in the room with the child during the virtual visit. So what measures are being taken to address screening for child abuse?
Well, we continue to ask those questions, those screening questions at each visit, whether it be telehealth or in person. Again, it is harder. I have to be honest, it is much harder in a telehealth setting because you don't know who else is in the room. And it's true, someone could be in the room and they feel uncomfortable about sharing a lot of this information. For those reasons, telehealth is not perfect, but and it's will never take the place of an in-person visit, especially in a school health-based or a school-linked center where a patient will feel much more safe and supportive. But if the person is in the room and you sense something is going on, then you can ask the yes/no questions. And that's when I say you really do reschedule to a better time, ask for if there's a better time that we can set up the meeting. And again, it's not going to be usual office hours, not during this time, because kids I'll never forget, can I call you back tomorrow? Yes. Can we do this in the morning? Sure. When can I call you? 7 p.m. So we negotiated to 6 p.m. You try to work with them. And so I think I got the call in at 6 instead of 7. And it was for a lot of reasons. The student felt that, you know, this was the one time that she had privacy in the house. So you try to negotiate with them. You may not get the answers right away, but especially if you sense something's going on, then you try to work with them and find the time to get the right answers.
I've had the same experience. Utilizing the chat box, yes, no questions, making sure people have headphones on. Our normal hours are till 8 p.m. So we're lucky in that way that sometimes they could, you know, sneak away after dinner. Also having young people use their cars as a private space was sometimes helpful. So I've had lots of young people move from like a living room or their room to the car, because if someone's listening at the door, you'll see them versus your bedroom, you might not know. I do agree completely that you should always ask. And I always ask at the beginning if someone else is there with them. And then I always ask before I ask any sensitive questions, has anyone else joined the room? Because there was one time when someone's sibling had come in and I did not realize, and then they started razzing their sibling while I was asking questions. So yeah, definitely want to confirm that privacy has been maintained throughout the visit, because you only have like literally one view of like 3 feet. So
Thank you. So we're going to take one last question before we wrap up. So have you had any challenges with students being lost to follow-up, and how are you getting those students back?
I can answer that in a short. Yes, we've lost a lot of kids to follow up. I don't know. It's a virtual world sometimes. If they're remote, I can't even say they're in the house that we last knew what their last address was. So they could be anywhere. So we have lost a number to follow up. It's been difficult. You do the best you can. And that's why it's important to get as much contact information as you possibly can. Email works sometimes best, just to keep in touch with somebody.
the same for us. We have lost some clients, and again, the email is really important, and same exact situation.
Thank you. So we want to thank everyone for joining our webinar today, and also a big thank you to our speakers for their time. Please make sure to complete the evaluation after the webinar has ended in order to inform future webinars. We're going to put the link in the chat. The recording of this webinar and the presentation slides will also be sent out to everyone who registered, and will also be on the NCSD and the SVHA websites. So thank you again to everyone, and have a wonderful day.